Thank you. Thank you very much for your introduction. And thank you, Claudia, for inviting me to this amazing symposium. I think it's so important to discuss the diversity in psoriasis. Okay. Those are my disclosures. Now, we are going to, Professor Mohammed before me spoke about the challenges in diagnosis psoriasis in the skin of color, but also it's quite challenging in treatment. We all know that psoriasis is easy to diagnose. Diagnosis is mainly clinical. Plaque psoriasis is the typical presentation with well-demarcated erythematous plaques with silvery laminated scales. Extensor surface of the elbows and the knees are almost always involved. Pruritic plaques, scalp, nail, and joints. And we also have guttate psoriasis, pustular, erythrodermic, and as he pointed out, they are more common in our part of the world, but as we are going to discuss again, but ethnicity actually might affect the degree of the severity of the disease. It's a chronic relapsing dermatologic disease with complex multifactorial etiology, as you've heard from Johan talking about the pathogenesis and the complexity and the bimodal distribution of psoriasis. And there was a bit of a study from the Global Psoriasis Atlas saying that maybe up to 400,000 persons are affected with psoriasis in Egypt, but I think we're going to find much more. I just wanted to explain the difference between race and ethnicity, because race is a combination of geographic, cultural, bioancestral, and socio-political influence, while ethnicity refers to people who may share a common national, tribal, religious, or cultural background. Currently, race is accepted as a social construct with the understanding there is fluidity in racial classification among different countries. And this is just a table to show the difference between race and ethnicity. And why am I talking like that? Because, for example, when Shun comes to present about psoriasis in Malaysia, for example, she talks about the Malayan population, the Indian population, the Chinese population. And as we all know, it's obviously different, and there is a difference in the incidence and the presentation. We are concentrating on the skin of color types 4 to 5 according to Fitzpatrick. But again, I'm going to talk to you about the Middle East. Maybe most of the references are talking about the African Americans or people who come from Africa, but I'm going to talk about the Middle Eastern population because we have a different color. The other day we were making a joke. I had the skin of color, and they say, I told them, I am a skin of color because I am not Caucasian or white, but I don't know what do they call me. But anyway,
skin of color.
Skin of color. I'm just tanned. My little granddaughter, she went to the beach. She became so dark. She says, I am black. I said, no, you are tanned. And this is the fashion now, so I am tanned. This reference has described talking about Black, Asian Pacific Islander, American Indian or Native Alaskan, Indigenous Australian, Hispanic or Latino, Middle Eastern, Arab, North African, individual who identify as non-white. Sometimes when we come to fill in a questionnaire about something, he said, identify yourself, are you white or non-white? And I think this is one of the references that said that people with skin of color make up to 40% of the US population. You were just talking about that right now. And I think more interest has to be given to skin of color. Adults in the United States, this is a reference that was published by April Armstrong and her colleagues, showed that the prevalence in white patients was nearly double that of non-white patients. Among Black adults in this study was 1.5%, which is almost similar to previous studies, and continuous efforts should be made to talk about the precise genetic and environmental contribution to this. This is, of course, the review article that was published by Andrew Alexis in talking about, this was referred to by Peter a while back, about psoriasis in the skin of color, the insights into the epidemiology, the clinical presentation, the genetics, the quality of life, the impact of psoriasis on these patients. And this suggests that although the frequency of psoriasis is lower in non-white individuals, but definitely it has a worse impact on their quality of life due to the, first of all, areas of involvement are a bit different, thickness of the plaque, more itching, more hyperpigmentation, and also the dyschromia that either hyper or hypopigmentation that is left after the cure of psoriasis, which is really worse. This is a reference that was published in the American Academy recently, part 1 and part 2, talking about the variation in genetics, biology, and the phenotypes of cutaneous disorders and skin of color in general. They were talking about psoriasis, atopic dermatitis, and other disorders. And they really, it was really very interesting because the classification mentioned that we have genetics, which was spoken about in details, we have clinical, and we have treatment. And today I'm going to talk mainly about treatment. The HLA-CW6 in Asian and the Middle Eastern populations, more associated with gut-tape psoriasis, with early onset psoriasis, with psoriatic arthritis, and it's higher among Black population. And the prevalence of psoriasis is lower among Black population as well, but other genes are responsible for contribute to the development of psoriasis in Black individuals. So I don't want to go into genetics in details, but it's because we've listened to Johan talk about it in details, but I mean, this is one of the things that's being studied right now, and HLA-CW1 is more prevalent in Asian and Middle Eastern population, and it is associated with increased severity in psoriasis and maybe associated with GPP, because as I'm going to mention, a study was done in an Egyptian center. They found we have a lot of erythroderma and a lot of pustular psoriasis, like Professor Muhammad was speaking a while ago. Also, there are negative regulators like CD69, the CTLA4, the FOXP3, and these downregulation of negative regulator was noted in Western large plaque psoriasis compared to the Asian small plaque psoriasis as well. Loricrene, which is a substance that impairs the barrier function of the stratum corneum, was found to be downregulated in patients of psoriasis. Also, for example, this paper is mentioning that there is a variable instance in sub-Saharan Africa. It's more in Eastern Africa than Western Africa. There is not a lot of literature coming out of our area, as I'm going to discuss right now, and I think we need more studies and more reports about patients coming from our area. And for example, in this study, they talked about Bantu-speaking and non-Bantu-speaking Africans. They thought that the instance of psoriasis varies widely between those two, and the African Americans were non-Bantu speaking. This was a study out of Dakar, Senegal, and I'm going to talk about it later on because they were talking about the type of treatments they use. This was a study that came out of Ethiopia, and in Ethiopia they found that it's not the matter of not having patients with psoriasis, but it's the matter of underdiagnosis, undertreatment. They have no access to therapy in a lot of the areas in Ethiopia. So I think there is a serious problem still in our area of the world. Clinically, we have the problem of erythema, we have the problem of sequelae, we have the problem of the body surface area and the scales, the scalp, and the small plaque psoriasis, which was described in the Asian population. Erythema really is not erythema. As you can see, and as some of the pictures were shown, this is one of my patients, which is really violet. It's not erythematous. Again, doesn't look erythematous at all. This is more white, more scaly. This is more violaceous. This is another patient with lesions of the elbow. They are not erythematous. This is another patient who can be diagnosed with difficulty as psoriatic and can enter into the differential diagnosis of other skin diseases like eczema, for example. Another patient with psoriatic arthritis and severe psoriasis on the shins of the tibia, which again can be mistaken for another. This patient actually needed a biopsy to confirm the diagnosis. And this is one patient that his lesions are more violaceous than erythematous. And this is a type of lesion that we see a lot, a bit of instability where the patient starts to develop some pustules at the edge of the lesion, like you can see the neck, the under the breast. And we see this color a lot, and we see this picture a lot in our type of patients. So erythema really is never a marker, and it doesn't help very much in the diagnosis. And I need to examine the patient for the nail, for the scalp, for other anatomic areas, which are typical with psoriasis, in order to understand. And I just, again, this patient might have post-inflammatory hyperpigmentation, which can be mistaken for active inflammation. And the patient is really very distressed. Why am I saying that? Because in a minute, erythema is supposed to be part of the PASI score. And I don't think that it can be used in evaluation of PASI score in our patients. This is, for example, a patient with lichen planus and a patient with psoriasis. I don't think the difference varies a lot. Long ago, they used to tell us lichen planus is itchy or psoriasis is non-itchy. And of course, this is a myth and it doesn't apply anymore. Professor Muhammad was saying, fungal infection is a differential diagnosis, lichen planus, sarcoidosis, lupus erythematosus, eczema. There is a long list of differential diagnoses in these cases. But how am I going to use erythema? This is the way erythema is evaluated in the PASI score. This is light red. This is red, but not deep red, although this is the way they evaluate. This is very red, and this is extremely red. And all what we have is dark, very dark violet, and I don't think it applies in the, we cannot use it as a marker in the PASI scoring. We have to consider pigmentary abnormalities, either hyperpigmentation or hypopigmentation, which are both caused with the involvement of interleukin-17, the tumor necrosis factor alpha. Either, this is an example of the hyperpigmentation, but also some of the patients, they heal with hypopigmentation, which in dark-skinned individuals, sometimes it's more depressing. And maybe this was described as the Warnoff ring, which is the depigmented ring that sometimes occurs around psoriatic lesions. And again, it's quite common in our part of the world. What about scaling? Scaling is usually increased. The areas are more involved because in our part of the world, and I think in all the developing countries, and maybe Claudia spoke wonderfully about problems in Chile, how she cannot reach her patients. The problem is divided into two. One aspect of the problem is the access to care, that a lot of the patients are very far from proper tertiary centers or dermatology centers where they can go and seek advice, and the treatment is usually really delayed, so the severity of the disease is increased. And the other part is difficulty in diagnosis when I don't have properly trained dermatologists in some of the remote areas. And again, there is ethnic differentiation and utilization of dermatologic services, because some of our patients, for example, tend to use, we were talking with Burma about Philippines, and we have the problem, but some of the patients just use natural products and plant products and do not go for treatment. So they have thicker plaques and they have more scaling. As you can see, these are really very thick scales, and they are very difficult to treat. So our characteristics of psoriasis in the skin of color, usually it's more itchy, much thicker plaques, less erythema, more purple, more dyschromia, whether hyper or hypopigmentation. The areas involved are usually different. We get a lot of scalp, we get a lot of inverse psoriasis, and the perilesional hypochromia that sometimes occur. What about scalp? Scalp, as you know, the severity tends to be increased, especially in African ancestry, because the women are less likely to wash their hair more frequently, and it's a problem. And again, it's a problem in the Egyptian population. If you ask a patient to apply any form of treatment on her hair and to wash her hair daily, she will absolutely refuse. So again, we are facing cultural habits. She will say, no, I cannot wash my hair every day, and this is one. This is the type of psoriasis we might see in some of our patients. This is very thick plaques of psoriasis. This is the smallpox I was talking about that was described in Asian population, which differs from guttate psoriasis in being more chronic and not associated with strep infection, and their plaques are usually larger than guttate. So why is treatment challenging? Treatment challenging because we do not have guidelines. The available treatments are, well, they're not available for everybody. Methotrexate and phototherapy have their problems, although they're excellent therapies because they're quite cheap. Scalp treatment is a problem, like I said, sometimes culturally. The paucity of biologics and the clinical trials that are missing. In the Middle East and Africa in particular, the incidence is high as in other areas of the world, and we, this week, we are going to sit with the GPA and see how we can do field studies, because I think it's under-recognized and it's under-treated. The literature regarding its management in this geographically large, culturally diverse area is very limited compared to the rest of the world, and I think it's the fault of us. We published a paper recently with Martin Steinhoff from Qatar and other colleagues, Alfred Hamoudi from the Emirates, talking about what are the unmet needs in the area of the Middle East. We don't have guidelines. The only two guidelines are present in the Middle East are, or rather in Africa, are from South Africa. And I just met the author right now because the last publication was in 2011, and he said in the process of doing the newer consensus, and Saudi Arabia have their own guidelines as well. But we don't, we just have, every center has his own guidelines without a national guideline. Paucity of published studies and guidelines again. 10 articles are archived in the PubMed during the previous 12 years, and I think this is very little. Only, like I said, 2 sets of guidelines. There are no mentioning in the difficult to treat areas or in pregnancy or in geriatric patients or in pediatric patients. They are not mentioned and do not take into account the regional variation because, for example, in Saudi Arabia, the biologics are readily available and supplied by the government, but this is not the case in our country, for example. They don't apply. Like I said, these are the South African guidelines. They're quite old, but they're in the process, or they're already, I think, publishing the consensus and updated consensus in 2023 about the use of the newer biologics right now. Kuwait, Iran, Tunisia, you will find very little studies. Again, very little studies about the comorbidities, although we do have comorbidities. One of the great studies that have been published recently by my fellow colleague and IPC counselor, Mohammed Komi, and they published their experience with around 2,132 patients from the psoriasis clinic in one of the big centers in Egypt, and they found, they described that mostly the psoriasis looks like other psoriasis elsewhere in the world, but to me, and when we discussed this, we found more instance of erythroderma and more instance of pustular psoriasis. We see a lot of pustular psoriasis, a lot of erythroderma, and I think this is maybe caused by inappropriate therapies in a lot of the situations. This is an example of one of my children. He is 7 years old, developed pustular psoriasis and developed very suddenly. It was quite difficult to treat. Again, there is a challenge in treating psoriatic arthritis in Africa and the Middle East. And this is, they only found, again, only 12 publications related to the burden of the problem in the Middle East related to psoriatic arthritis. What about the choice of treatment? In high-income countries, they choose according to the severity, impact on the quality of life, presence of comorbidities. We still have this hierarchy in terms of systemic treatment must be tried first, and then if not, we go to the biologics, and we need to go to the cheaper biologics. In the meantime, we do have biosimilars in Egypt, but I mean, and then if it failed, we move to the following biologic. And I think this wastes a lot of time because sometimes we know that a certain patient will not respond to a certain biologic. Presence of comorbidities are not considered very much, and I think they have to be done more. We think about economic availability, which is fine and understandable, and things have gotten much better because at least we were able now, the government health insurance has introduced the biologics in treatment of psoriasis, which is a great achievement. And all the children, all the school children are treated no matter what they have, no matter what they need, with the government health insurance. So I think this is wonderful because we can easily, for example, I can easily prescribe a biologic to a child from the school age. Methotrexate, we use a lot of methotrexate, and I think it's one of the great successful drugs. We're talking about viral hepatitis, but we have eliminated this problem, not anymore. And even our liver colleagues say, don't worry, just use it. It's quite safe, and we were talking about, we don't need to do even, we do regular checkups of the liver functions, but I don't know, are Egyptians more immune to methotrexate? I wonder, but they respond very well. And I give a lot of children methotrexate, they do respond well as well. But sometimes we have contraindications, sometimes the patient doesn't respond. The problem with methotrexate, it's quite slow, especially if a patient needs a faster response, it's not easy. Again, this was reported from Senegal, showing the inappropriate treatment. They use a lot of phytotherapy, which is inappropriate, and sometimes it worsens psoriasis. They delay the use of proper treatment, and sometimes this worsens psoriasis. Phototherapy is great, and it's cheap, and it's available. It's sometimes, although it may exacerbate the hyperpigmentation caused by psoriasis, and we don't have the problem or long-term problem of skin cancer like in the Caucasian white population. It's a good option for our patients, but again, it entails sometimes that the patient has to travel for a long time, for a long distance, 2 or 3 times a week, which is not always easy and applicable. Scalp is difficult anyway, and it's difficult in our part of the world because the women do not tend to, they take care of their hair, they don't like it to be messy and smelly and greasy, and it requires frequent hair washing, and it's usually ineffective, and we need really to choose a treatment that's compatible with the hair care practices and cultural preference. Everybody, every woman, every other woman now in our part of the world is doing one form of treatment to her hair or another, with hair straightening and chemicals and the washing frequency. All these have to be considered when I'm treating the scalp. For example, washing with a prescription shampoo, sometimes it's not suitable even for African Americans because, again, will lead to non-compliance and the patient's dissatisfaction. What about biologics? Biologics, this is a study that was done about rheumatoid arthritis, found that the self-injectable biologics, the patients were unfamiliar with it, and this was only a single study. But again, this was published in the Middle East by Anwar al-Hamadi and his colleagues, talking about that the psoriasis comorbidity like metabolic syndrome, obesity, cardiovascular disease, psoriatic arthritis are common in the African and in the Middle Eastern patients, and they're undertreated. And its cost effectiveness is one of the key challenges. And like I said, not every country is like the same. So we thought about having regional guidelines. I don't think they're going to be very easy because at least we can have a consensus among all the areas into how to treat our patients. Like my colleagues before me said, all the skin of color groups are underrepresented in all the clinical trials, and we need more participants. I think Andrew Alexis is having a new clinical trial included specifically for the skin of color patients, and I found this study by CIMAL as well with brodalumab and in patients with skin of color, but I think we need to do more of that. In Egypt, we are much better, definitely much better than maybe 5, 6 years ago. Psoriasis is beginning to be recognized more and more. The government has seen that they need to fund those patients in a lot of situations. Maybe the pharma companies are trying to help. The prices have gone down sometimes. We have more biosimilars, so I think when biosimilars were introduced, this sort of forced the pharma companies to put their prices down, and I think it's extremely important. We've solved the problem of HCV. Of course, maybe Now, with the devaluation of the Egyptian pounds, maybe we have another problem coming up. But anyway, I think this is just a worldwide problem, and I think we will be able to overcome it one way or another. We have everything in Egypt right now, all the anti-TNFs, the anti-IL-17, the anti-IL-20. We have ustekinumab, the interleukin anti-23, and we have biosimilars as well. So I think this will help a lot. Patients fund either out of pocket or through NGOs or private insurance or state-sponsored national health institution. But the problem is sometimes comes with the duration of therapy, because sometimes they only say the patient has to take the treatment for only 6 months or only 1 year, and we have to reapply and beg them for an extension. So what we try to do is space the treatments or convince the patient to pay out of pocket for a little while. It's sometimes not easy because they have to stop the treatment. Again, we need more physician awareness because a lot of the dermatologists still do not want to prescribe biologics. I need to educate them more, put some national guidelines, better access to biologics, and more biosimilars available. We do master classes, we lecture, symposiums, webinars. We keep telling our younger dermatologists, please, you can easily use biologics, and this is important. So I think at least thank you, Chun and Claudia, for organizing this, because this gives us another meaning to international. We've all talked about our local problems, and we have to suggest strategies in our own countries, national guidelines, a good registry, more research, patients advocacy groups, and I think IFPA is going to help. So finally, I would like to press upon the point that the genetically mediated differences in the clinical presentations, complications, and consequences of psoriasis between the various ethnic groups inhabiting Africa and the Middle East and the Caucasian in the Western world will warrant definitely, like Johan was saying, further investigation maybe in the 10, 15 years, the coming years. And there's an urgent need to develop a strategy to implement this. And I would like to thank you very much.